Okay. Very good morning to everyone. So I'm the opening batsman for day 2. So today I'm going to discuss about Coracoid split during arthrolatarjet. The strategy 1, strategy 2 will follow after this presentation. So this is one of the worst complications that can happen with the surgery, which is considered to be one of the very difficult ones. So let me share my experience when I had this complication. So I'm Bibek Basukala. I come from Kathmandu, Nepal. So thank you, team MCS, to have me here again. So before starting my presentation, so many things in world happens with accident. Many good things actually. This X-rays, cement, the plastic, the vaccines, all these things was a serendipity. It happened by accident, and it changed human life for good. Similarly, the procedure, the Latarjet procedure, was a serendipity. It was an accident. There was a TRIA procedure where the inferior coracoid were osteotomized, not completely osteotomized. It was partially osteotomized, and it was a sort of green stick fractured, and subscapularis was displaced inferiorly. This was a TRIA procedure. One fine day, Mr. Mitchell Latarjet visited TRIA theater, and he tried to copy his procedure, and unfortunately he completely broke it. And what he did was he put that coracoid piece right in front of the glenoid. Thus, the Latarjet procedure was evolved. This was an accident. So, this is one of the most, I think, artistic surgery in shoulder. It is, every step is artistic. It's an art. This open surgery itself is very difficult, and this Laurel office converted it to the arthrolatarjet. So let us go to the case details. I had 26-year male. He was a student. He is gym lover, and he had repeated his history of instability of his left shoulder. 10 times he could recollect, maybe more than that, but he had multiple episodes of instability like subluxations. Overhead activity he has completely restricted. He had stopped going to gym. History of easy dislocations, sleep time dislocations was also present. There was no ligament laxity, no history of seizures. Examination was obvious. Apprehension test was full. The range of motion was full. Strength was okay. Apprehension test was possible in both 90-45. So it suggests some form of bone loss. This was the true AP X-ray, which shows cortical rim sign, that is, there is some bone loss. So CT scan was done. It showed significant bone loss. The line is straight here, and this is 3D recon. So obviously, what we thought was he needs some form of bony reconstruction. We thought of Latarjet. This is the MRI picture. It also showed good bone loss. So plan was arthrolatarjet. We just started doing the Latarjet. It must be, I think, 8 or 9 cases in our practice.
Bibek, I would like to interrupt you here. I would just like to get a general feel from the audience. One thing is very clear, some kind of a bony procedure needs to be done, which in most people's hands is likely to be a Latarjet. Now, a show of hands, for how many of you is the preferred way to do an arthroscopic Latarjet? All right, so only 2. So my question to you, Bibek, and I am in the majority, I mean, I would like to do an open Latarjet. Why do you think of arthrolatarjet? What are the advantages you think it gives over an open Latarjet?
So my ARS 3 is right.
Okay, so we'll get to that.
So we will discuss it. So my plan was Latarjet, and as I have already mentioned, first 7 cases went very well, so we were very excited. So this case was also planned arthrolatarjet. Everything went smooth. This was final step. The bone piece, the coracoid piece was being mated with the glenoid anterior surface. But there was a problem. The coracoid was not agreeing. It was not sitting flush with the glenoid. I continued screwing in superior screw, then inferior screw, then superior screw, then inferior. It was not agreeing to mate with the anterior glenoid. It was not getting flush. There was gap always present. I was doing it again and again, and finally what happened? Finally there was longitudinal split from the inferior screw, as it is not going, it was not actually hugging each other, and finally this very bad complication happened. The inferior split was there. So it's gone. I didn't know what to do because I had never had this complication. I have never seen this complication because I have seen masters doing it. They never had this complication. So I don't know what to do. So there was a problem. We had no idea what to do. We were less experienced. I talked with Professor Amit. He also had no idea. So what we did was we went back to patient and patient party. We did some counseling. So that brings to my first ARS questions. ARS questions, please. So if something like this happens, be it open or arthroscopic lethargy, what will you do? Use the remaining graft. Sometimes remaining graft can be used. Okay. Use the remaining graft and fix it with glenide. Okay. That sounds good. We also thought of doing it, but the piece was so small, we didn't think that it will add up to the bone loss was so high, so we thought of doing something else. So this is my next question. If the split, ARS2 please. So if you do not use that split coracoid as a main graft, if you do something else, there is a conjoint tendon that is detached along with the coracoid, what will you do? Let's go to literature review. I'll keep it for some time what we have done. I'll reveal it later. So the literature review, when I dived into the literature about the coracoid, there is lots of paper on complication, and this is one of the most quoted paper from Laura Lafos and Ashish Gupta. They said that despite excellent long-term results, complications are still high. Even in best of the hands, it's up to 15 to 30%. There are intraoperative complications, post-operative complications. Intraoperative complications are graft-related, like high graft, low graft, nerve injuries, vascular injuries. These are not in arthrolatarjet. These are both in open and arthrolatarjet. There are immediate complications, immediate complications like hematoma, delayed complications like infection, long-term complications. These are not in surgeon's control. I put it back. And long-term complications which are not in surgeon's control are non-union, osteolysis, arthritis. We don't have control. Even best joint lethargy can have these complications. We are concerned with these complications which are surgeon-dependent, graft-related and something. And this complication was, I think, our issue. So as this is the person, the Babulkar sir, from whom I learned arthroscopic graft, he used to say arthrolethargy is one procedure which needs an utmost attention. Each step has to be done perfectly. For the perfect result, you have to check all the boxes right. I think I made something wrong in this particular case. So this is all graft-related complications. This is perfect arthrolethargy. This is high graft, low graft, medial graft, lateral graft. Everything can occur. And what we had is the worst complication of graft that can be possible. This is the split graft. So why did it happen mainly in arthro? I never had this complication in open lethargy because arthrolethargy are associated with this. You know, there are multiple papers where it tells about the learning curves of arthrolethargy. They say it takes a surgeon 30 odd cases to be perfect in arthrolethargy, and it happens. So this paper says open lethargy is still difficult, and I also do think that. And significant decrease in operating time occurs after this learning curve. Intraoperative complications decreased, arthroscopic to open conversion decreased, and time decreased, patient satisfaction, even hospital stay decreased according to this paper. So these are five papers they did systematic review on, and they said that after this learning curves is completed, both open and arthroscopic lethargy are comparable in results and everything. So that brings to my third ARS question. Third ARS question, please. So this brings to Raju sir's question. So do you think arthrolethargy is the future? It is better than the open? I always get this comment like Roshan Wade said just, you know.
You know, it's not debate in India. If you go to AOS also, I remember 6 years back there was a debate between Laura Lafos and Giovanni Giacomi from Italy. Same topic.
So I think the audience has answered the question, isn't it?
Yeah, audience has answered 70%.
The hall was unanimous. AOS hall was unanimous that arthrolethargy is more and more complicated procedure. The complications are masked by the surgeon. They don't tell the people that these are the complications. And probably Latarjet is a better choice. Open Latarjet is a better choice.
So I don't know. I'm not that. I have that volume arthroscopic Latarjet surgeon, but I have grown through open Latarjet, then arthroscopic Latarjet. I have had complications, which I think I would not have.
Let me ask you, how many Latarjets you have done till now? Open.
Open Latarjet, I have not have number, but arthroscopic Latarjet I have number. It's 16, 17 till now.
And open?
Open more than that of 100%.
So, to master a technique, you need more number and then only you can learn arthrolatarjet. So you have to have that
I
kind of
think
volume.
going into arthrolatarjet, what I have grown myself is, I have been a good shoulder surgeon. I'm no more scared to play around shoulder. So by doing arthroscopic Latarjet, by venturing arthroscopic Latarjet, I think I am being able to go to so many places of shoulder, so many areas of shoulder which arthroscopically I could have. So as a surgeon, I have grown. And first few cases, like 8 to 10 cases, I had problems. Now when I do, I think I am in the middle of that learning curve. And every surgery grows like this, you know.
Very true, and I think it makes subscapularis repair look like a piece of
100%,
cake. Anterior
100%.
interval release, looking at the axillary nerve, all
Everything,
these things
everything.
become
Even the
things of
brachial
second
plexus
nature.
dissection, the which
Yes.
Frank will discussing.
Yes.
So brachial plexus dissection surgery, no one can imagine if he cannot do arthrolatarjet. So once you do arthrolatarjet, brachial plexus is just there, and it's another few tricks. So
And Bibek, in
if
the
you-
interest
yeah.
of time, can I request you to advance your slides?
yeah, sure. So there are many salvage technique. Dr. Ayyappan will talk in subsequent slide. This is his. There are many others like how to salvage this graft. And we chose, what we did was we kept it safe and simple. That is, we converted to open. We didn't bring our ego in between, converted to open, harvested the ICBG graft, used same subscap split, and ICBG graft was fixed with 2 screws. Problem was the inferior screw hole was, we tried it multiple times and it became loose, but that same screw hole was getting loose. That's
So your first sentence has everything, you know. The first sentence.
yeah.
So
So,
whenever you're in trouble, please convert to that.
so this is what we did. The screws are not parallel. We were not happy actually, but we had to do it because inferior screw was getting loose. We had to do some angle type of fixation. So this we didn't do anything to that particular conjoint tendon graft. It is lying there freely. We didn't fix it with the glenoid or the graft. So this was what the problem. So we went back, we studied again our videos, and why we split was, I think we did not follow the steps carefully. Coracoid graft preparation was not taken seriously. This is what happened actually when we saw the coracoid graft. There was a big of the, when the coracoid osteotomy was done, big was there. In open surgery that is clearly visible, but in arthroscopically, the early surgeons, the naive surgeons may not visualize this big properly. We didn't excise it actually. And when we continued bearing it, continued screwing it, it broke from there. So this was what happened. Actually, we should have done the big preparation like this, and then it would have been perfect arthroscopic Latarjet. So these days, I make sure that these things is well taken care of. I learned from this case, and I spend quite a time preparing this coracoid graft. This is 1 year follow-up. Patient is good. He is happy. He is back to his gym. But I called him and did the X-ray. X-ray looked not so good. The screw looks open, and this is the recent CT scan. Everything is resolved. The glenoid has reshaped, but the screws are more prominent because osteolysis, which is not in our control. So I think we have to remove this screw. So it's not take-home message. What we learned from the case was, have a good rapport with patient. This patient never complained me about change of surgical plan, everything, because I had very good rapport with patient. Surgery is an art, so it had to be planned and executed each step properly. It's not about rushing, it's not about speed, it's about perfect results. So do not rush, and analyze and learn from your mistake, and do not repeat those mistakes again. Thank you.
Thank you so much, Bibek. This was very nice of you to come and discuss this complication.